In the next final chapter, I will show 1-minute brain teaser to quiz your knowledge and ability to identify what is abnormal during surgical bronchoscopy. Good luck! I hope you got the answer right. This is a normal bronchoscopy, except it's the wrong way around. This is a situs inversus, a rare congenital abnormality in which the lungs, heart, liver, spleen, and other viscera are transposed in a mirror image to the normal arrangement, also known as situs solitus. When all organs are involved, it is called situs inversus totalis. The condition occurs in one person in 100,000 of the population. The majority have no symptoms. In the right chest, one expects to see a left lung arrangement of 2 lobes and 1 fissure, as well as the heart, descending aorta, and the spleen. In the left chest, there will be right lung arrangement of 3 lobes, 2 fissures, the SVC, the azygous vein, and the liver. Let's go through the details of this bronchoscopy and see how we arrived at this diagnosis. On entering the main stem trachea, one cannot help to notice those little chondromas on the cartilaginous framework of the trachea. This is TO, or tracheobronchopathia osteochondroplastica. We can practically ignore it. Note that TO does not occur on the membranous part, and the goblets of secretions might be mistaken for chondromas. The primary carina looks sharp and healthy. The orifices of the right and left main bronchi also look normal. The left main was entered first, which might suggest that the abnormality is on the right side. However, this was a random selection. Immediately on entering the left main bronchus, one notices its short length of 2 to 3 cm, whereas one would expect to see 5 to 6 cm of normal left main bronchus. Also note that the 2 main divisions are not in a vertical axis as could be expected from a left side arrangement, and that the upper lobe is offset at 9 o'clock rather than 3 o'clock in the normal arrangement. However, so far we saw no endobronchial lesions. On approaching the division that is supposed to be the upper lobe bronchus, the Mercedes sign becomes apparent. One would expect only 2 divisions in the normal arrangement, the lingular and the upper division, whereas here we have 3 divisions. When the scope is advanced towards the lower lobe, it is noted to be longer than the normal, and this is the arrangement of a bronchus intermedius. The lower lobe divides into 3 divisions, whereas only 2 are expected, LB6 and the common basal. So far the arrangement is suspicious of mirror image of a right lung, with a hint of a left middle lobe. Situs inversus should head the list of differential diagnoses at this stage. On withdrawal of the scope and advancement into the right main bronchus, a short right main is expected, but this one is almost double the normal length. We have two divisions at the end of the right main bronchus, and the membranous part tells us which is the lower and which is the upper. The upper lobe is not at 3 o'clock, but offset at 9 o'clock, and this is abnormal. When approaching the lower lobe, we note the very short bronchus, which cannot be a bronchus intermedius. Therefore, this is a lower lobe proper, and it looks like a mirror image of a left arrangement. We then examine the upper lobe orifice, and we find 2 instead of 3 bronchi. There is no Mercedes sign here. On further scrutiny of the subsegmental bronchi of the upper lobe, it becomes clear they are exact replica of the left side, albeit the other way round. Putting it all together confirms the diagnosis of situs inversus. This is all I have in my library on abnormal bronchoscopies. This cannot be comprehensive. Therefore, I strongly recommend cross-referencing with material published over the net. This chapter concludes the series about bronchoscopy for thoracic surgery. I hope you find it useful, and thank you for watching. Goodbye.